The first item of business this morning is to review and approve the minutes from the September 9th, 2015 meeting, our last meeting. Are there any comments to make on the minutes?
I have one.
Yes.
Look at the, oops, sorry about that.
Item 1, the vote.
Item 1, the vote, I believe Dr. Caro voted no. That's not reflected in the minutes, so that should be corrected.
Yes.
That's correct. There was one no vote on the repeal of the direct oral suction rule from Dr. Caro, one abstention from Dr. Richardson, and all others present at the meeting voted in favor. The minutes should reflect that. Thank you. If there are no other amendments to the minutes, Dr. Foreman, thank you, as ever. May I have a motion to approve? Second. All in favor?
Aye.
So the minutes passed, are approved unanimously, and we'll move on to a resolution to amend sections 201.07, 203.07, and 205.07. These were published in the City Record on September 21st, and a public hearing was heard on October 23rd. There were 2 written comments received, and no one testified. This is for the board's consideration to adopt. If you could introduce yourself.
My name is Stephen Schwartz. I'm the New York City Registrar of Vital Statistics. As the commissioner said, there were 2 comments received, both pertaining to Section 207.01C, relating to allowing funeral directors to make certain corrections to the death certificate using our electronic death registration system without first obtaining departmental approval. They were in support of, both of the comments were in support of the resolution. And then there was one minor change to the proposal. The department had proposed, is proposing to give the Office of Chief Medical Examiner the same rights as funeral directors to make certain corrections to death certificates. This will provide the same efficiency to the medical examiner's office as to funeral directors. Any questions?
Any questions? If there are no questions from the board, may I have a motion to approve?
Second.
And all in favor?
Aye.
Anyone opposed? It passes unanimously. Thank you. The next item is for the board to consider for approval for publication. So this is a notice of intent, a proposed resolution to amend Article 13 of the Health Code regarding laboratories. And we have a presentation from Dr. Varma and Dr. Aikman. If you could introduce yourselves.
I'm just trying to figure out which. I don't think our presentation got loaded. Which one is it? I sent 2, one about Zika and then one about our COVID health, and then formulations. Yeah, but there's another one too. Or 2.
No, there were 2 of them.
There were 2.
Yeah, Julian said there were 2.
Where is our honor?
Do you want to reverse the order?
So are we going to be looking for, no, that's okay. Should we move on then to the second proposed resolution while we get the presentation sorted out? This is now item 4 on today's agenda, a proposed resolution to amend Article 131, buildings generally. Do we have the people here in the room to present? Yes, very good, thank you. Good morning, if you could once you get the presentation up, which it is here,
Yes, hi.
you could introduce yourself.
Okay, got it. Hi, I'm Chris DeAndrea. I'm the Director of the Environmental Health Assessment and Communication Program with the Health Department. And to my right is Dr. Maureen Little, toxicologist within the program. And she'll start the presentation.
All right, so for those of you who don't know, perchloroethylene is a non-flammable chlorinated volatile organic compound that's very commonly used in dry cleaning. It has a very characteristic odor that many people associate with dry cleaners. It's widely used not only in dry cleaning but also in metal degreasing and other applications. And after December 2020, use by dry cleaners that are co-located in residential buildings will be effectively prohibited by federal regulations. Sorry, technical issues. Okay, so some of the health effects of PERC are that although there are acute exposure issues that could affect your irritation of your eyes, skin, and effects on the central nervous system, we're mainly concerned with the chronic effects of PERC that would be more relevant for the exposures that people might encounter. And those would be effects to the various organ systems, but particularly we'd be concerned about liver cancer and other issues with color vision and possible elevation of other types of cancers. It's classified by EPA as likely to be carcinogenic in humans and by all routes of exposure, and it is probably carcinogenic in humans from the International Agency for Research on Cancer. In New York City, the vast majority of New York City dry cleaners use PERC and have been using it for some time. More than 75% of these establishments are co-located in residential buildings, especially in Brooklyn and Manhattan. In 2009, based on the New York State guideline, the Board of Health established 100 micrograms per cubic meter as the nuisance level for PERC vapors in co-located residential or adjacent buildings. And in 2013, the New York State Department of Health decreased its guideline for PERC from 100 to 30 micrograms per cubic meter. And that was, that aligned, and we would like to change the health code to align the New York City nuisance level with the New York State level. Okay.
Okay. Just to go over some of our actions. So over the past 5 years, fiscal years, we've had 55 unique complaints regarding dry cleaners. 25 of those locations receive sampling. Sampling is typically done in up to about 5 locations in an apartment. And the results of the initial round of sampling, and we'll go back multiple times as needed, but the initial round, 13 of those had one sample above our current health code of 100 micrograms per cubic meter. 6 of those, all the samples were below 30, which is what we're proposing. And in 6 locations, we had at least one sample between the 30 and 100. So lowering the nuisance level may result in some businesses being compelled to improve practices, the operation of that equipment to reduce neighbor and tenant exposures in those situations. So the proposed reduction in the nuisance level we think is consistent with good public health practice, current research, and will be consistent with the New York State guidance. And lowering the nuisance level will be more protective against PERC exposures and potential adverse health effects. So, if you have any questions?
Now open for questions, Dr. Foreman.
Thank you very much for the presentation. I've encountered PERC in a number of situations with childhood exposure. So until 2020, it's still allowable to have dry cleaners co-located in residential buildings?
That's correct.
Why is this categorized as a nuisance exposure as opposed to a health related? And the reason I ask that is I recall that the odor threshold varies from person to person and may be much higher than 30.
Well, the odor threshold is higher than 30, And so we're concerned about levels that can't be detected just by smelling. As far as the nuisance, my understanding of the nuisance in the health code is that it is a health-based, that a nuisance level is something that is degrades the air and can cause health impacts. So as I think by definition in the administrative code, nuisance and health are tied together, more in the technical term.
In terms of PERC and residential buildings, the big concern on the children's environmental health side is long-term neurocognitive impact. And I know there's some studies, at least in adults, that look at visual discrimination and subtle issues. There's not a lot of great studies on children. There have been a few daycare centers that have been co-located or close by in the past. And these solvents do represent, I think, a real hazard to young kids in particular. So I certainly applaud lowering this level as much as possible. I'm eager to see it not occur in buildings where people live.
Dr. Richardson, followed by Dr. Karen, was there?
Yes, thank you for the presentation. So I noticed that there were more than twice as many complaints, unique complaints, as there were investigations. What is it that prompts an investigation?
Well, we look at all of those complaints. The only reason we will do sampling is if we confirm, for one, there's a dry cleaner on the premises. Sometimes people make complaints about dry cleaners, they turn out just to be laundromats and there's no dry cleaning equipment on the premise, so we're not going to do that specialized sampling. We'll still inspect the situation, but for other conditions. Sometimes people will complain about dry cleaners across the street, so the impacts are going to be attenuated through the atmosphere. It's not going to be an impact situation, so we wouldn't go ahead and do sampling in those situations.
Thank you, Dr. Richardson. Dr. Karen?
Just to educate us, what the small business can do to comply with the regulation, change the chemical, reduce the amount. What choices do they have?
They're fairly tied to the equipment that they own. So what it comes down to is really taking the measures that they need to be taking in the first place, which is controlling emissions. Oftentimes we find that for example, if we have an elevated level, we'll order the business to hire an engineer to take a look at the equipment and the facility to make sure it's functioning properly. Oftentimes we're finding that gaskets are old and the equipment's exhausting improperly, and there's work practices that aren't being followed. And once those measures are taken, we'll go back and we'll resample and we find that the levels are controlled. So there are measures that they can take, still using the perchloroethylene to control. We also work, by the way, with DEP closely since they permit these establishments. So we have a working relationship with them, and any engineering reports, it's DEP reviews, and we work with them on prescribing what should be done in certain situations.
Thank you. And Dr. Redlener?
Thank you. Thank you for your report and information. One question that came to mind when reading this information is that this seems to be this evaluation of the environmental levels of PERC only in response to a complaint, a residential complaint of odor. And I'm just wondering, for my own information, are there regular testing of the environment of the dry cleaning associations themselves in terms of the impact of the odor on the employees or other surrounding residents? And if you can't smell it over 30, I mean, is it really just based on smell as the nuisance?
No, it's not based on that at all. I mean, it's strictly on testing that we do that's specific.
But I mean, the
for a
smell
complaint.
is what
What prompts
generates the complaint,
But
right?
oftentimes the complaints are related to other odors and fragrances associated with the dry cleaner, so that there's apparent odor coming from that facility.
Mm-hmm.
Also, sometimes it's prompted just by concerns about they see exhaust coming out from below their window. So it's not necessary that people smell it, but they often smell something associated with the facility that prompts their complaint.
Mm-hmm. And is there monitoring of levels of PERC in the dry cleaning establishments and just?
Not by the health department. The workplace is regulated by federal OSHA, Occupational Health and Safety Administration, and so dry cleaners are required to ensure that their facilities meet those requirements, but I'm not certain that they're doing that.
Okay, thank you.
Dr. Klitzman.
Hi, good morning. Thank you, Chris. Thank you, Maureen, for the presentation. And also, I know this issue of addressing perk overexposure in apartments co-located with dry cleaning establishments has been one that the department has been involved in for a couple of decades. And I am glad to see that we're taking a more health protective approach. And also, I feel like compared to a couple of decades ago, there are far fewer dry cleaning establishments using PERC that are co-located in buildings with residences. But I also want to ask you about the impending EPA rule in 2020. Can you tell us a little bit about the plans to help dry cleaning establishments move away from PERC, and how's that going, and what are the trends that you're seeing in terms of businesses moving to safer procedures and safer substitutes?
There have been some moves from, we've been somewhat involved, but it's DEP is also involved in trying to get them to move to alternative solvents or to make them aware of alternative solvents. Some of those have posed more health concerns than the PERC, and quite frankly, the major solvent that many of them will be adopting is DF2000, which is a hydrocarbon-based solvent it's made by Exxon. There's some similar products, and those don't have any health information, and that is a concern. But EPA says it's good, so.
Dr. Gada.
I want to thank you all for this presentation and the effort to be in alignment with the state regulations, as well as thinking ahead for our own cities and our health of our citizens. Have you all, I'm thinking about the people who have lived in residential areas that are co-located with the dry cleaners for years, who might not have been aware of the risks and harms over these many years. Is there any effort to have an educational outreach to those people, or any surveillance of individuals who may have been chronically exposed to PERC over many years?
Not so much surveillance of the people, but we are planning an outreach effort to do a rough survey for people who would like a survey of their apartment with some new equipment that will be hopefully have purchased by the end of this fiscal year. So that will enable us to get a sense of PERC levels, and then if we find levels, we can go back out with the standard method and take action as needed. So we are planning to do something a little bit more, robust come this summer.
If there are no further comments or questions, may I, just to summarize, this rule change will bring our health code into alignment with the state regulations. This is going to be published for public comment, and I'm sure many of these issues may come up during that period. May I have a motion to approve? And,
move to approve for public comment.
And all in favor?
Aye.
Anyone opposed? So we pass unanimously for publication the resolution to amend Article 131. Thank you very much.
Great, thank you.
Are we now ready for item 3 on the agenda, the resolution to amend Article 13?
morning. I'm Dr. Jay Martin. I'm the Deputy Commissioner for Disease Control at the New York City Health Department.
Dr. Jennifer Wakeman, I'm the Assistant Commissioner.
Sorry, I'm the Assistant Commissioner and the Lab Director for the New York City Public Health Laboratory.
Okay, so I'll go ahead and discuss today a proposal that we have to
Put on your mic, please.
Oh, there it is right there. To amend Article 13, which is to require that high containment research laboratories register with the department and report incidents in those laboratories. So what is a high containment research laboratory? It's any laboratory facility that stores or handles microorganisms or any type of hazardous biological material. These can sort of basically be understood as those that operate at what are called biosafety levels 3 or 4. These are levels that are set by standards that are promulgated by CDC and NIH, and they're widely understood within the laboratory community. A biosafety level 3 refers to any laboratory that handles agents, and we use the term agents because it's not just live microorganisms, it can be toxic agents as well, that can cause serious or potentially lethal infections, and that may infect people via an aerosol, that is through the air. Some examples of this are Yersinia pestis, which is the causative agent of plague, Bacillus anthracis, which is the causative agent of anthrax, and then SARS, which, as people know, caused a very large respiratory outbreak in the early 2000s. BSL level 4 is a level that's reserved for what are considered to be exotic agents that have a very high mortality level and no effective treatment. And so some examples of that include variola, it's the causative agent of smallpox, and then of course Ebola. When it's being cultured, mind you, not for PCR. How many high containment research laboratories are there in New York City? Well, this is the purpose actually of this notice of intent. The number of what we call BSL-3 labs in New York City is not known. We do know by various federal sources that there are no BSL-4 laboratories in New York City. Some of these high containment laboratories are registered, which is called the Federal Select Agent Program. So this is a program that's governed, again, by federal law that requires laboratories to register with the federal government if they store or handle a specific list of organisms or toxins. The number of laboratories registered in the U.S. is increased from about 415 in 2004 to over 1,495 in 2010. The federal law prohibits the federal government from actually disclosing the identities of the laboratories that are actually on this list. So the regulatory challenge that we face is that the state, New York State, regulates BSL-3 laboratories that perform clinical diagnostic services. So any laboratory that reports normally results back for human health purposes is required to be registered with the state, and so the state therefore has a regulatory oversight over how they manage their work. However, there are no city or state agency regulations for research laboratories. So these are either private industry or public academic laboratories. Labs that are registered with the Federal Select Agent Program are required to report the theft or loss or release of any biological agents to CDC and to local law enforcement, but there's actually no requirement in the Federal Select Agent Program that they report those incidents to the local health department, which has the potential to cause delays. Also, the regulatory gap is that although CDC will allow us to obtain the names of laboratories from the Federal Select Agent Program through a special agreement, all we would get from that list is the names of those laboratories. We would have no data about actually what agents that these laboratories work on or their protocols for how they manage incidents. And then I think probably the biggest concern that we have is that not all high containment research laboratories are actually part of the Federal Select Agent Program. There are some pathogens of concern that are not covered by the Federal Select Agent Programs. These include MERS, which is the Middle Eastern Respiratory Virus, extensively drug-resistant TB, prion-related diseases, chikungunya virus, and then of course any pathogen that's undergoing what's known as gain-of-function research. That, for example, research on influenza in which people are trying to enhance its transmissibility to understand, mechanisms by which pandemics arise. So our challenge is that we know that the risk of an incident occurring from laboratories that do this type of research is actually very well established. There have been community outbreaks that have been documented to be caused by laboratory incidents, and there have been laboratory incidents very recently at federal laboratories that did not result in outbreaks, but resulted in an outbreak of concern. It's important to note that none of these events actually happened in New York City, and I'll just briefly show you some examples of these incidents. Here are some examples of community outbreaks that have originated as a result from research laboratories having challenges with handling infectious agents. So this includes influenza H1N1, smallpox, multiple incidents involving SARS virus, and then foot and mouth disease, which is a zoonotic pathogen. There have also, as I mentioned, been incidents at federal laboratories. 3 of them have occurred at CDC and were reported in 2014. And in 2015, one was reported at the Department of Defense laboratory. None of these incidents actually resulted in human health risks, but the potential or consequences of an incident could have been grave had there been any slight alteration in what ended up happening. So the proposal that we're going to make first involves creating some definitions. The first is, defining what a biological agent is, and what's written in the proposed amendment includes a detailed description of that, and clearly delineating what is a research laboratory. So again, just to emphasize that the state already has ample regulations covering clinical laboratories that do human health. So our research laboratories we're going to define as one that is used primarily for research, development, storage, examination, or testing of biological agents. And this will specifically exclude any laboratories that are already regulated by the New York State Department of Health. And we will define a high containment research laboratory as one that operates at BSL 3 or 4 levels, as defined by CDC and NIH. And as we discussed, I think these are universally accepted, across the research laboratory environment in the United States and basically globally as the standards for assessing laboratory safety. The proposed amendment involves all of these high containment research laboratories to register with the health department before a new facility operates or within 180 days if they're already operating, and requiring to renew that registration every 2 years. What we're going to require is actually not that much information, but more than what we would get from CDC through an MOU, which is the name and contact information, the locations of those laboratories, the BSL levels that they're operating at, importantly the name and immediate contact information for the responsible official, and then a list of all the biological agents being used within the high containment research laboratory. We are going to require that any theft or loss of within this high containment research laboratory be reported to the department by telephone within an hour. The following information will need to be provided during that report, which is the name of the agent, the estimated quantity of the agent that may have been stolen or lost, and the estimated time in which that theft or loss may have occurred. And it also requires that any exposure incidents be reported to the department also within an hour. And an exposure incident would be an example of somebody tripping and a vial breaking open, or a sample being mislabeled or mishandled in some way such that it left the BSL 3 or 4 environment accidentally. And we'll also require that detailed information about this incident be reported to us so that we can take steps if necessary to mitigate any public health consequences. So I'll stop right there, and Dr. Raikman and I are available to answer questions.
Any questions? Dr. Foreman?
Thank you very much, Dr. Foreman. I did have one question. This certainly seems like a really important thing for the New York City Department of Health to do so that you can track these labs. I was wondering if there are any non-research labs that are at level 3 or level 4 that report to the federal program that are missed or not included in this regulation, because those labs would be still delays in you getting information, and the information you get through the MOU with CDC would still be limited. And if so, could those labs are we allowed to include that in the New York City regulations?
So this would be a lab that falls outside either the clinically regulated labs by New York State would not fall under here. I think the only thing that would fall under there would be a federal lab within New York City, which we know of at least 1 or 2 that have BSL 3 level laboratories. There's one run by the FDA in Jamaica. So we would not be able to require them to register because they're federal labs. We do know they exist, and we could potentially get that information from the federal government if they were willing to give that to us. But that is one example that would not fall into either of the either the New York State regulated category or the category that we would be able to register.
If I could just follow up, just so I understand, why is it that we could not mandate that they report since they're within New York City? So look at Tom.
You're gonna bump that Tom, I think.
I'll get back to you.
Yeah, we have, I mean, just as an example, we have challenges, for example, with the VA hospital system with reporting of infectious diseases because they're within the federal government, and there's been ongoing challenges with that. But we'll follow up on this in more detail.
Yeah, I mean, generally a federal building is outside, but being in the city, I don't know, but generally we can't regulate federal, it's just outside our jurisdiction.
But I appreciate that they're all in New York City, and I appreciate the impulse from the board that we are responsible for the whole city, regardless of who the provider is.
I want to thank you for this, Dr. Varma and Rickman. I was really surprised that we don't know how many level 3 BSL labs there are in the city, and so our ability to really track that and be able to respond in a timely fashion if something happens is critically important to our Department of Health, so thank you for this. You know, I noticed that that once registered, they would re-register or reapply every 2 years. How often does a laboratory change or add to its biological agents being studied? And if that happens at a relatively, at a frequency that could be concerning, is there a provision that's going to be put in place that asks them to update us in a shorter time frame than when their every 2-year registration comes about?
So we do ask them, thank you. We do ask them to update us if anything changes in the interim between those 2 years. There is that requirement for them to renew every 2 years so that we do sort of catch up with every lab at that time. The frequency with which a research lab might add or change the agents that they're working on, I think, varies by labs. Many labs, you know, they have federal grants and they, you know, have a project moving forward. They don't necessarily change course rapidly. So it would really depend on the lab. If they got a new grant, we're able to start a new project that involved new agents that they were working on, then they might add agents in a time frame shorter than that 2-year frame. But we do ask them to report any changes to us immediately.
Thank you.
And I thought, Dr. Gowdy, you might be getting to the question of whether this would be burdensome on the labs. Do you want to make any comment on that?
So we've talked to a few labs and asked them what they felt about this, and they all were actually quite happy about it, because what we can then offer to those labs is a contact at the health department. We can provide them with help about doing biosafety risk assessments. We can provide information and support, and they do want to partner with us, and it's helpful for them. They can add that to their risk assessments and their plans that they need to have in place to fulfill the requirements of their grantors and funders and everything else. And it's helpful for them if there was an incident. They're going to look to us if they did have an incident for help with handling that, particularly if they had a researcher in their lab who had an accidental exposure. We're their first line of help to make sure that that person is appropriately treated and moving forward. This will also help us moving forward because somebody who has an incident in the lab and falls ill is going to seek medical care. And we also want to be in touch with the medical facility and the clinical laboratory that's going to be handling those patient specimens to ensure that those specimens are handled appropriately, because depending on what the potential organism is, most likely those specimens are going to end up coming to our lab to handle, because we have the facilities to be able to handle those types of agents at the public health lab, where many clinical laboratories do not. So it helps form a good partnership.
Thank you. Dr. Klitzman and then Karen Redlener.
Hi, thank you. I'm trying to understand a little bit better our relationship with federal agencies and their relationship with these laboratories now, and the potential for this rule to help improve communication and health protection. So, for example, you alluded to a possible MOU with CDC or other federal agencies. Is there a way, have you thought about whether this rule could be used to just have federal agencies provide what they already know? It sounds like some of the information they collect is the same. It sounds like some of the requirements are the same. Could you help us understand that a little better? Thank you.
Yeah, part of the challenge is that the Federal Select Agent Program is governed by federal government security restrictions, and so they actually have a very rigid security clearance procedure for who has access to that information, and the terms of that MOU are actually, we're still negotiating. There are 2 other jurisdictions that have similar types of regulation, the City of Boston and the State of Maryland. So I think it's a topic we can continue to discuss, but we've always, there have been ongoing challenges because of these issues about security and when information is disclosable or not, which is why there may be some duplication of effort and work, but in our estimation, we think that duplication will both be beneficial to the City of New York as well as not unduly burdensome. But you are correct, it's one of these things that there should be an easy solution to, but for various sort of legal restrictions, mostly because of security concerns, is more challenging.
Svetlana.
Actually, the security concerns was the topic of one of my questions. I certainly support the idea of getting this information and having it available in the Department of Health. I'm just wondering if there are specific plans to keep this information, about lethal agents, at a level of security that would not be available to many individuals.
Yeah, and so we do have plans to have this list very well secured. It would be accessible by only a very small number of people, and it would not be accessed unless we needed the information. We do have a very few of us that have security clearances in the health department, and that is the list that we would start with on who would be able to access. People have already been vetted by the federal government as trustworthy to have access to this type of information.
Yeah, so we have within the laboratory, we have, because people have to work on the Select Agent Program and to also attend FBI briefings, we have a select number of people who have high-level government security clearances, and so those would be the same people that would essentially have access to this list as well.
And I want to point out, we reached out to the Committee on Open Government, which is the state body that administers the Freedom of Information Law. We got an opinion from them that this is a record that we could keep confidential.
That's excellent to know. I had one other question. Thank you. Also understanding that there are risks from accidents and incidents and exposures that happen internally. Just also wondering if this information, how it could be available to emergency responders in the, the possibility of a fire or explosion or something else that would then have, emergency responders coming to that environment, or, is there some sharing of information that's appropriate for the fire department or other emergency responders?
Yeah, so we have talked to Whitney a bit about this as well, but they also have access because they would be going potentially into a laboratory space in the event of a fire, and they do work directly with the laboratories. All these laboratories are required to have FDA compliant permits. Our lab has that
The
as well.
VSL3 as well?
Yes, and so all those permits include information that Whitney has that are required for them to be able to do their job in the event of an emergency.
Thank you.
Dr. Richardson.
Yeah, so this may be more of a question for Tom, but I see that this includes defining research laboratory, and the term used is facility. And I guess I'm interested in whether or not an entity, which is also referred to, could have a joint laboratory that, because it is already regulated its clinical diagnostic activities by the state, somehow there's a loophole because of the way this is worded. And I don't know what the best way to word it to avoid that is, but a facility could be a building, it could be a campus, it could be something large that has joint purposes, and is there a potential loophole that the wording needs to address? I would just throw that out there maybe for legal to look at. I'm quite sure that many private industries, for example, may have joint activities going on in a single building, and would this be a way out, or a single university or something? So I just wonder if the definitions are adequate to attain the purposes that we're really going after.
Good comment, Dr. Caro.
Do you foresee any problem with when a lab is doing research in search for with a patent, meaning they will be afraid to stealing information, a spy type of incident?
I would say that I think the biggest challenge we would face is we'll never know what we don't know. So there may be facilities that just don't comply, and we won't be able to know that. Our plan is, we have pretty good extensive networks throughout the academic and research communities, and so our attempt is to, if this amendment is approved, to promulgate it as much as possible, and hopefully at the same time address any concerns that might exist about trade secrets or other things. But yes, it is possible for a laboratory to not comply and us to never know about it, and unless God forbid something did happen.
Dr. Foreman.
I had one quick follow-up question regarding the FDNY permits. Do the federal labs need to have FDNY permits?
I was going to look into that. I noted it, and I think they may. And so this gets right. So I don't think we could make them report, right? But to register, that's what I'm not sure of. We'll look into that. But we generally can't make we can't assume jurisdiction over a federal. We've had problems with like restaurants in the Federal Reserve, for instance, resisting our registration. But to report the fact in, and federal buildings are generally subject to like fire protection rules and things like that.
Thank you.
We do have existing relations. We do have existing relationships with some of those federal labs that are within the city, just because we do work with them as part of our daily work, and so they're not resistant to working with us in general.
Good. If there are no further questions, may I have a motion to approve? And second? All in favor?
Aye.
Anyone opposed? It passes unanimously. Thank you very much.
Yep.
All right, this brings us to item 5 on the agenda, which is a proposed resolution to amend Article 161. Good morning, and if you could introduce yourselves.
Good morning, I'm Corinne Schiff. I'm the Special Projects Director in the Environmental Health Division.
And I'm Mario Merlino, Assistant Commissioner of Veterinary and Pest Control, and I'm delighted to talk about the changes to Article 161 as soon as we work the computer. And So, up to now, if you had a pet shop in New York City and you sold only cats and dogs, or you sold cats and dogs, you needed a permit from the New York State Department of Agriculture and Markets. We did not the health department did not regulate them under Article 161 of the Health Code. If you sold other types of animals, small animals, we do have, those are covered under the health code. So if you sold only cats and dogs, you had only a agricultural markets permit. If you sold both small animals and cats and dogs, you had a permit from both agencies, the health department and ag markets. And if you sold only small animals, you had a permit from us. So we were preempted under ag markets law. In 2014, the state changed that law, allowing local regulation of cats and dog sellers. In 2015, the city council enacted a suite of pet shop related laws. The focus of those laws really to ensure humane treatment of the animals, and also to make sure that animals are sourced from humane breeders. For instance, a feature of the new local law is that pet shops cannot purchase animals from breeders that have a history of USDA violations, right? And there's other requirements, including they have to be microchipped. They have to be spay-neutered if they're at least 8 weeks old, and they have to be licensed, have a dog license. And there's many other paperwork requirements, and including the right of prospective purchasers to look at the sourcing of animals, and purchasers to know what the healthy animal is when they purchase it. So these are, sort of improvements in how dogs and cats are handled in New York City. So what we're asking is, the health department is now charged with enforcing the new pet shop laws. Those pet shops have to get a permit from us. And so what we're asking is that, and I think I have it here, it's not the board is not required to approve the new law. The health department has to enforce the law as written by the city council, but we're asking that we align the health code with the administrative code. Very important that we don't want the health code to say that dogs and cats sold, salvaged dog cats are excluded from the health code, is what it says now, and have the administrative code say that the city regulates dogs and cat sellers. So entities that have to follow all these laws, we want to make sure that it's clear what they have to do. So in the health code, there's 2 places where we're changing the text. One is in Article 161, where it says in 2 different places that sellers of dogs and cats are excluded from Article 161, so we're taking that text out. And then in Article 5, we're including the permit fee, which is part of the admin code, now there's the city council law for sellers of dogs and cats. It's a 2-year fee, 2-year permit with a $300 fee. For other types of permittees, it's a 1-year permit with $70 fee. So that's going to be included in the health code. And so with that, we'll answer questions.
Thank you. Are there questions from the board? In sum, this will bring the health code into alignment with the administrative code. If there are no questions from the board, may I ask for a motion to approve? This is for publication for public comment.
So moved.
All in second, I need a second.
Second.
And all in favor, please say yes. Raise your hand. Yes. All right, and nobody opposed. So it passes unanimously. Thank you very much. We have an additional item that we thought would be of interest to the board that we're providing for your information. It's an update on the Zika outbreak.
Great, thank you very much. We wanted to provide an update to the board about Zika virus, which I'm sure many of you have read about in the news, and describe the current context of the outbreak, how it impacts New York City, and what we've been doing to prepare and respond to this. So just for background, so that everybody has the same information, this is a virus that is primarily transmitted via the bite of an infected mosquito. Taxonomically, it's considered an RNA virus, a flavivirus, very similar to other viruses that are transmitted similarly by mosquitoes, such as dengue, West Nile, yellow fever, and St. Louis encephalitis. Before 2007, there had been sporadic outbreaks recognized in parts of Africa and Asia. In 2007, there was the first large-scale outbreak that was detected, which was in Micronesia. Subsequently, there was documented spread throughout various parts of the Pacific, and then recently in 2015, it reached Brazil, and it has now been documented to be circulating widely in multiple countries throughout Latin America and the Caribbean. Because the primary transmission mode is via mosquito, it's important to understand a little bit about what mosquitoes transmit it. There are many, many different types of mosquitoes. The mosquitoes that have been implicated in transmission of Zika virus are known as Aedes mosquitoes. These are very aggressive, day-biting mosquitoes. They're found commonly throughout tropical climates, including parts of the southern United States. This map here shows the distribution of the vector that's been implicated in the outbreak in Latin America and the Caribbean, known as Aedes aegypti. And as you can see, there are parts of the southern United States in which this mosquito has been found to be distributed. What's challenging about these mosquitoes is that they lay eggs in domestic water handling containers. And can be everything from the lid of a soda can that has a little water on it, or a little extra water in a flower pot, or a cup that's left out. And they live in and around households, which is where they lay their eggs, which breed. Because Aedes aegypti is this vector that's found throughout the southern United States, there's a tremendous lot of concern about transmission throughout the southern U.S. As of now, this vector has not been detected ever in New York City. We do, however, have a relative of Aedes aegypti, known as Aedes albopictus, which is found commonly in New York City. It is uncertain right now how efficient or ineffective of a vector this would be. Again, as we know right now, it's Aedes aegypti that's the most efficient vector of this virus. This just shows you a map updated as of a few weeks ago about all of the countries in which Zika virus transmission has now been documented to occur by mosquitoes, and CDC is constantly updating this list. It's basically safe to assume that anywhere south of the continental United States right now is at risk of transmission, except in the furthest, southernmost reaches of Latin America, of course, which are undergoing their winter season right now. Now, in the continental United States, local transmission of Zika virus, just to emphasize, by mosquitoes has not been reported yet. Since 2011, there have been laboratory-confirmed Zika virus cases identified in the United States among travelers returning from areas with local transmission. So these are imported infections into both New York City and other parts of the United States. And this is to be expected. We see cases of malaria, of dengue, of chikungunya routinely in New York City, but these are all infections that were acquired somewhere else, and the person returned to New York City and happened to develop their illness while they were here. With current outbreaks that are occurring across the Americas, however, we expect that the number of cases among U.S. travelers will continue to increase. And imported cases may result in the virus being introduced and then local spread in the United States. So again, just to understand the pathogenesis, a person returns from another country, having been infected in that other country, they have virus circulating in their blood, and if the efficient vector, the mosquito, the Aedes aegypti mosquito, bites that person, takes what's known as a blood meal from that person who has the virus in them, it is then possible for that mosquito then to bite somebody else. So it is certainly possible and probably expected that there may be local transmission in parts of the United States which have this mosquito and have people returning from areas where they may have been infected already. So again, just to emphasize, transmission is primarily mosquito-borne from the Aedes aegypti. We do consider other Aedes species, such as Aedes albopictus, to be potential vectors. We know that this is potential, we just don't know how likely they are as vectors. There are, however, other modes of transmission that have generated publicity and concern. This includes maternal feeder, transmission from a mother who is infected while pregnant to her unborn baby. Sexual transmission has now been reported. This has been now documented in a number of different countries in a number of different ways. All of the cases that have been reported to date have all been situations of a male transmitting to a female via condomless sex. And there was also reports of transmission by blood transfusion, which again is to be expected because this has happened with other similar mosquito-borne viruses. The infections that are produced by this are actually quite benign. In most situations, estimated as often as up to 80% of infections may be and produce no symptoms at all. Among those who do develop symptoms, the period from infection to development of symptoms can be up to 12 days. The most common symptoms are a fever, a rash, joint pain, conjunctivitis, and this illness tends to be fairly mild. Symptoms really will generally last only a few days, or maybe up to a week, and it is commonly mistaken, again, for other similar mosquito-borne viruses. There's no specific treatment that is available for this infection, similar again to dengue and chikungunya, which have no specific treatment available. But severe outcomes are uncommon but have been documented to occur. These include Guillain-Barré syndrome and ascending flaccid paralysis, which is very well documented from a whole range of infectious diseases. And then, of course, there are concerns about infection during pregnancy. And this is really the area that we're most concerned about. It's important to understand that the data about this is limited and changing literally every day. What we know right now is that infection may lead to birth complications, such as spontaneous abortions or fetal malformations. And the most widely reported right now is microcephaly, which is a very small head, which often translates to small brain and other impairment of fetal development. But it is likely that there will be reports of other malformations, because usually what's commonly reported at the beginning of the outbreak may only be what's considered the tip of the iceberg. We do not know, however, the magnitude of risk and the factors that predict pregnancy complications. We don't know the magnitude of risk and factors that predict fetal malformations. And we don't know the spectrum of fetal malformations, as I said, whether or not it's only microcephaly or a much broader range. So who should be tested? This slide here shows the groups that we are recommending testing in. There may be other situations in which testing may be warranted, but these are the most important ones. These are pregnant women who traveled to an area with Zika virus transmission. That's important, even if they don't have symptoms. There are persons with one or more compatible symptoms during or within 4 weeks of having traveled to an area with transmission. There are neonates who have microcephaly or intracranial calcification. So this is a radiographic finding who are born to women who traveled to an area with transmission while they were pregnant. And then persons who travel to an area with Zika virus transmission who present with Guillain-Barré syndrome. This slide goes through in detail the different types of laboratory tests are available. I won't go through this in much detail, but just to indicate that there are two different sort of categories of testing. One is what we call PCR or molecular testing, testing for the DNA fragments of this virus, or the RNA fragments specifically of this virus. And that can be done both on blood and on urine. The challenge with this test is that it has to occur fairly recently during the period when the person is infected, because the virus circulates and then the body clears it. The most important test, though, however, is a serology test. So this is testing for antibodies, your body's immune system reaction to the presence of infection. The challenge with the different antibody tests that are available, however, is that they cross-react. People who are in an area where they could get infected with Zika virus are also people that could have been infected with dengue or chikungunya or other flaviviruses. And this cross-reactivity between a test has been a very big challenge and is an active area of research right now. So some of the important things to keep in mind then about testing are, first of all, there is no commercial test yet available. For New York City residents, that means testing is being done at our public health laboratory under Dr. Rakeman's guidance, and at the New York State Laboratory, as well as at CDC for some selected cases. And there are a number of challenges to developing a commercial test, both for PCR as well as serology. I won't go into those now, but if people have questions, we can discuss those later. And I think the other big challenge we face is that the interpretation of these results can be quite complicated. PCR is very easy to interpret. It's either essentially positive or negative, and there are very few indeterminates. It's the serologic testing that and an interpretation that's been quite challenging. For prevention, again, to emphasize there is no vaccine available. This is an area of active research. All individuals right now who are traveling to affected countries should really take steps to avoid mosquito bites. This is really our most important recommendation. That is particularly important for women who are pregnant, and we're strongly advising women who are considering travel to reconsider that travel until we know more about best efforts to prevent infection. And now, because of the possibility of sexual transmission, we also have some recommendations for both males and females who have traveled to affected areas. The health department's Zika response is similar to what we do with other infectious disease emergencies. We're focusing on public awareness, disseminating guidance that we have, adapting that guidance as it occurs, educating providers and assisting them with diagnosis. This is turning out to be probably the biggest challenge because we're also coordinating and performing laboratory testing. We're investigating suspect cases and doing epidemiologic investigations to confirm that transmission occurred outside of the United States and not either locally or via sexual transmission or bloodborne. We're working on monitoring systems to monitor pregnant women and provide support to them and their offspring. And then probably most importantly, working on mosquito control plans. Right now is not mosquito season, but within April is when we start to worry about mosquitoes, and then obviously as the summer goes on, it becomes much more of a challenge. We do face a number of challenges in doing this work. How many New Yorkers are at risk currently and in the future? This is a rapidly changing outbreak. We have a very challenging time understanding what the dynamics will be. Will the epidemic in fact expand to the southern U.S. states, or will the emergency mosquito control measures being taken there, as well as ongoing lifestyle factors? We have air conditioning and screens that many developing countries do not, whether these will change the dynamics. And then, of course, will Aedes albopictus, the Aedes type that we have here in New York City, actually be a competent vector in our environment or not? We just don't know. So this slide, I guess it doesn't show up quite as well. This shows a summary of some of the response that we've had to date. We've mobilized over 200 health department employees. We've spent over $2.8 million doing our response activities to date. And our estimates are that as this outbreak expands, we could be spending over $20 million for all of those activities that I've mentioned. Probably the biggest and most challenging is the testing and monitoring of patients. We've coordinated testing for over 1,400 patients in New York City, tested over 900 samples. We're receiving, in terms of patient numbers, anywhere from 40 to 50 patient specimens a day. But because patients submit multiple specimens, that translates to upwards of 150, 200 specimens that we actually receive every single day in our laboratory now. We've received inquiries from over 3,000 providers, and those continue all the time. We're working with the media, doing media interviews, particularly in Spanish language media, done community presentations, and these are continuing to expand. We're now expanding to community boards, and we're going to be very soon launching a very widespread mosquito prevention campaign that you'll be seeing on the news and hopefully via social media as well. In terms of cases in New York City, we've had 16 cases updated through last week. All of these, again, have been confirmed to be travel associated, and 2 of them occurred in women who are pregnant. I'd say, just close by saying, our most important message to the provider community is the importance of reporting. One advantage is right now we're the ones doing laboratory testing, so we can be quite confident about all positive cases being reported to us. But of course, we also want to make sure providers know about reporting Guillain-Barré syndrome, about any child suspecting of having a birth defect that might be associated with Zika. And then our 1-800 number is available all week long to provide both reporting as well as clinical consultation for providers. I'll stop right there.
All right. Thank you. We're open for questions for Dr. Varma.
Thank you, Dr. Varma. Very interesting. I had one question. You made a recommendation that all asymptomatic pregnant women who return from affected countries, which is a very large area now, should be tested. And I'm wondering what that will do to their volume. That could be quite a large number. And what the reasons are for testing that population. Do we offer different prenatal care and follow-up to those patients? Is it for epidemiologic tracking? What is there to gain? We have no treatment to offer. And we don't have local transmission at this point. So it just seems like you could get, and you would induce anxiety
And we don't even know what the prevalence is of adverse birth outcomes in people who are asymptomatic and infected. So it's a very complicated picture.
Yeah.
No, you've touched on all the critical issues. Yeah. So the fundamental. So in terms of volume, yes, it represents. I think about 60% of the specimen volume we have right now is from pregnant women. So,
and that recommendation to test all pregnant women who return, even if they're asymptomatic, I don't believe that's known in a widespread way amongst.
And that's one of the things that
when it becomes better known, that number could go way up.
Correct, and it will also continue to grow up as the affected areas, if you have transmission in Florida and Texas, where there's obviously huge amounts of travel, and right now in Puerto Rico, obviously we have a huge population of people from Puerto Rico and the Dominican Republic. So yes, so we're very well aware of that. So the challenge fundamentally is, you can look at this from a number of different ways. From strictly a clinical decision-making perspective, you're absolutely correct that a woman who was exposed and had traveled there's not much that we have to offer at this point. We have discussed this extensively with maternal fetal medicine experts. We held a consultation actually at City Hall about this. And our decision to offer testing is based on a couple of things. I think one is the principle that patients have the right to know, even if there is not a decision that they can make on that. They want it because it's information that they believe to potentially be of prognostic value. The second is that, for epidemiologic purposes, I do think it's important to us to know because we need to get some sense about the potential range of birth outcomes that may result as a result of these infections. And I think the third is, as information changes, there may be interventions that we can offer them. In terms of clinical management, maternal fetal medicine experts have told us that the reason they think it's most important is, number one, they think it will potentially provide information to them to look for more extensively for other birth defects beyond microcephaly. And knowing that range of, knowing that there is that risk stratification can help them in managing the delivery. And then for pediatricians can help with the evaluation afterwards to look for hearing defects, blindness, or other complications that might be associated with other birth defects.
Do you want to comment, Dr. Varma, on what the recommendations have been of the CDC?
Yeah, so CDC has made the same recommendation. There was a lot of back and forth over the first 2 or 3 weeks that this became common. CDC's original recommendation was only to test women who had a reported history of symptoms. And then it changed about, I think, 2 weeks after that to a broader recommendation. I think that was because of these reasons that I've outlined.
Dr. Foreman.
I just wanted to follow up that I guess what concerns me is that it does introduce a certain amount of stress to potentially a large number of women when we don't really know what their risks are. And I wait for that first call when a woman who's early in pregnancy finds out she was exposed and didn't get sick and says, should I terminate my pregnancy because I don't want my child to have microcephaly? And you're going to get those calls.
Yep, and we
have gotten them.
How to answer that.
Yeah, and the particular challenge is that the detection, at least of microcephaly, is not reliable at the standard, second trimester ultrasound. It was going to require later trimester ultrasound. So, we're not making any recommendations, and nor should we at any point right now about the management of that pregnancy, other than vigilant observation. If a woman is found to be positive serologically or by PCR. Sort of vigilant observation by a maternal fetal medicine expert, regular ultrasounds to look not just for microcephaly but other birth defects, appropriate management of the delivery if there are other birth defects found, and then follow up with a developmental pediatrician after birth to look at the range of potential complications.
Yes. Well, and of course, the best place to study this is in Latin America, where large numbers of women have been exposed, and of course, those cohort studies have been established, and as well as case control studies being conducted both by the World Health Organization and by the Centers for Disease Control. Are there further questions from the board on Zika? All right. Well, thank you very much, Dr. Varma. And thank you. There being no further business, I declare the meeting adjourned.